And now I'm going to ask Dr. Glaros to share some information about TCD and hopefully answering people's questions that we hear a lot from people in the plans about indications, when it's not required. And I'm going to ask Corey to come up here and make sure that this gets, that Dr. Glaros is.
Because I'm also a tech person. I'm not at all. I just figure it out. All right. Do you have what kind of thing do you have? Do you have
this one?
Okay, so I think what we do is we put this thing on this thing. I'm a very good tech person. And then that should work, maybe? Question mark? Success.
Is the easiest tech thing
That's
I've
right,
ever
I
done.
know.
Good
It's
job.
the system, it's not me. Okay.
Do I have to stand close to this one? Hopefully everybody can hear me. So, I think, and I've probably spoken to some of you about this. I know I've been in communication with Corey about it, about our efforts to improve. Is that better? Can you hear me? Okay. I'll do this. It's like a fireside chat here. No, I'm too loud. The part of this, the success of this initiative really came out of this meeting, and to be honest, because this is something that I had already been working on really since I started at Children's and trying to improve TCD rates, and it wasn't until I came here and Gary and Corey started sending me just how bad these rates are that I had the background information and buy-in from plans, and some of the discussions with plans helped me actually convince our hospital to get on board with this in terms of the financial viability of this. And so this is sort of what we've been doing to increase TCD rates, and I have some pretty exciting data to share at the end. So we get a lot of questions about, and Madison, who's our nurse, Madison Morin, so she can raise her hand. Some of you have talked to her, but she's phenomenal. Some of the questions we get are, who needs a TCD, and is this patient really missing a TCD? Do they need it? Do they not need it? So Corey asked me to just give a little background on this. The sickle cell disease, we all know is, multi-system disease, affects every organ in the body, and one of the most devastating organs to be affected, or the devastating complications, is stroke, right? And the lifetime risk of an overt stroke for someone with sickle cell, or for the population of sickle cell disease, is 30%. And that includes ischemic and hemorrhagic strokes. On the pediatric side, we're really dealing with ischemic strokes, almost exclusively, but not universally. 30% of children will have silent strokes. I know we've gotten questions about that before. And when we do screening MRIs on adults with sickle cell disease, 50% have evidence of a silent stroke. And a silent stroke is just an infarct in the brain that never caused symptoms. We never saw it, we never knew it happened, but it still increases your risk of a secondary stroke or a recurrent stroke, and it can have impacts on cognition and executive functions. And so, the complications of a silent stroke, it's not just that the stroke itself was silent because we didn't see symptoms, but the long-term sequelae are even silent because it's hard to pick up on those things. But 11% of children will have an overt stroke by age 20, meaning, weakness on one side, slurred speech, whatever it is, the classic kind of stroke symptoms. And this goes back, 30 years to the cooperative study of sickle cell disease when, we looked at symptoms with sickle cell disease over many, many patients, and the results were 11%. So more than 1 out of every 10 kids would have a stroke with sickle cell disease, and that's the highest risk condition for stroke in the pediatric population. But that's without intervention. So after we identified that data, we found there are ways we can prevent these strokes from happening, and those rates have dramatically reduced, but only if we are able to implement those interventions, right? And that's what we're talking about. The highest risk period is in the ages 2 to 5, and that gives us a very small window to intervene. And I can tell you, even in the last 5 years, I think in our hospital we've had 6 or 7 strokes, something in that range, which is way too many in this day and age. And 100% of those patients either didn't have a TCD or had a delayed TCD. Every single one. If we do these TCDs, it really works at identifying stroke risk. And so we've had more questions about transfusions and how does that impact this. So the risk of a recurrent stroke after an initial overt stroke is 70%. So it's very likely you're going to have another stroke. And so actually our center, Dr. Ingrid Sarnik, was one of the first people to identify that if you put patients on chronic transfusions after a stroke, you can prevent that second stroke. The risk is still there, but it's dramatically reduced, I think in the 10 to 20% range. And so that's kind of where all this started, that we had an intervention that could prevent strokes. After identifying we could prevent recurrent strokes, the STOP trial came out in the 90s. And basically what we found was if we use TCDs to identify stroke risk, then we can start those chronic transfusions before the first stroke, and that's primary prevention. And so the recommendation, I think that's on the next slide, but basically what the TCD does, it's an ultrasound Doppler that looks at the velocity of blood flow. And the idea is the narrower the vessel gets or the less compliant, the same pressures behind it, it makes the blood flow faster, right? So higher is generally worse. There's a few caveats to that, but that's generally the story. So greater than 200 centimeters a second we consider abnormal. And between 170 and 200 centimeters a second we consider conditional, and that's based on the fact that there was still a stroke risk for those conditional patients lower than if it was abnormal. The higher you get, the worse, the more at risk you are. And also when you're conditional, there's a 20 to 30% conversion risk, meaning in the next 6 to 12 months you're probably going to become abnormal. I shouldn't even say probably, because it's 20 to 30%. Most will not become abnormal, but if the longer you go, the more likely you're going to become abnormal. Your TCD is going to become abnormal, I should say. And if you have an abnormal TCD, there's a 9% annual risk. So each year, it's a cumulative risk, right? So the longer you go just walking around with an abnormal TCD, the higher your risk of stroke becomes. By intervening with chronic transfusion therapy, we can reduce that stroke incidence by 90%. More so than if you've had a stroke already. If you have just an abnormal TCD, if we can intervene early, we can reduce that stroke risk dramatically, almost down to what it is for the general pediatric population. But chronic transfusions come with alloimmunization risks, risk of delayed hemolytic transfusion reactions, iron overload, which has been discussed a little bit. And so it's not without risks. And so, you know, as you're, again, for all of these interventions, we have to be very careful that this is nothing that we're doing is just 100% benefit, right? There's always risks, there's always benefits. In this case, the risk outweighs the benefit. And, you know, there's a discussion about chelation for another day, but the other way we can protect against stroke is with hydroxyurea, you know, another big focus of this group. And we found that hydroxyurea can be as protective as chronic transfusions in the case of abnormal TCD. If there was already a stroke, it's not as protective. In theory, just because that vascular damage is already so bad that it's just not enough. And so the recommendations for TCDs are between ages 2 and 16, every patient with genotypes SS and S beta 0 should have a TCD every single year. And as you know, everyone in here knows that we're nowhere close to that, you know, 100% recommendation. or we haven't been. And if we have a conditional result between 170 and 200, depending on how high it is, there's a little nuance there. We repeat that TCD anywhere from 6 weeks to 6 months. So we're doing that more frequently in that case. If it's abnormal, we bring the patient back on a short leash, like 1 to 2 weeks, and we repeat it. If it's still abnormal, they're going on transfusions. But, I put this obvious statement: adherence to this recommendation is poor, and that is nationwide. That's not just Region 10. That's related to, access to a quality sickle cell center. That's related to quality radiology departments that understand the importance of this. That's related to barriers to care and on the patient side, communication between the health system and the patient. We've had issues in the past, it's different for every patient, but we've had patients call radiology the same day asking if they can get in for a TCD, and the person on the phone says, we don't do TCDs here. And we have 850 sickle cell patients. They do, 200 of these a year, or they were supposed to be, and they don't even, the person answering the phone doesn't know that they do it. Or they say, we'll call you back, we have to figure out the schedule, then they call back, they can't get a hold of people, and it's the phone tag game, right? Or we have a patient in our clinic and we say, you go down right now, we get it set up, but because our clinic is inefficient, that patient's been sitting there for 2 hours, it's now time to pick up the other kids from school, and they're like walking out the door, they say, oh shoot, I can't do this right now, and they leave, right? So it's a different thing every time, and what I had decided, I'm not the only one, but basically there are too many barriers on our end, on the patient's end, in between, to, I wanted one solution that was gonna fix everything, right? That's the dream. And there's been papers out there as far as if we have patient navigators sitting in our clinic and helping patients get to their TCD appointments, and we do same-day appointments and all this kind of stuff, but it's very much in a clinical trial setting or a study setting where there's more resources, there's incentives and that kind of thing. And those efforts where it's basically just like, I'm gonna help you get there, they're not sustainable. Those studies have shown, we'll get up to 70% for a year, and then the next year it goes down, again to 20%, whatever it is. And so what we said is if the patient comes to clinic, they should get their TCD. And so for years, I was going to pharma, I was going to, different grant agencies saying, if you give me a machine to put in my clinic and someone to do it, it doesn't matter what the patient barrier is. If they're in my clinic, they're getting a TCD, right? And so finally, after 2 years, the MDHHS came out with, this sickle cell expansion program, and we were lucky enough to get one of those grants. And we got $100,000 to support a TCD machine and an ultrasound technologist in our clinic. And she sits in our clinic all day. She watches the schedule. She knows who needs a TCD herself. We don't even have to think about it. She pulls them out of the waiting room while they're waiting for 40 minutes, because that's how our clinic operates. She does a TCD, they go back to the waiting room, then they come see us, they already have the result. And so we started doing this in July. And essentially the idea is, I don't care what the barriers are, I'm just eliminating them all. The barriers become getting you to clinic. And that is a barrier, but that reduces significantly. Now I don't have to get you to 2 appointments. And repeats become a lot easier because we can do them there. If the patient comes back in 3 months, we'll do it again if we wanted a repeat, right? So we've had patients in the past where we do a TCD that's conditional, and we say we need this repeated in 3 months, and then a year and a half later, we're like, oh, geez, they had a conditional, So this is, Corey asked me for some pictures of our setup. This is on the right, just our hallway entering in from the waiting room, right on the side. These first couple rooms are where our MAs sit. They do vital signs, they do lab work right when the patient walks in. And the third room over here is what's up in the left-hand corner. We had a room that we were just using for storage. We put the TCD machine in there. And our technologist sits in there and she just pulls them right in. So it's right by the waiting room. And she doesn't even need an order, because she knows who needs them. She'll do the study, and then after the fact, then she'll say, hey, can you put this order in? And then we send it down to radiology. Because I also don't need the radiologist to read these. I can read them myself. I actually read them in more detail than the radiologist does, And this is, just basically what the printout is on the TCD machine. We're looking at middle cerebral artery, anterior internal carotid, posterior cerebral artery, and we look at peak velocities. We look at the mean average time, the time average mean velocity, or maximum velocity, and we just look at the numbers and go off the stop criteria essentially. And so the exciting thing is our radiology. We started this in July, early July. So we now have 3 months of data. This is what our radiology department sent us for the last 4 years. In each of those months, how many we did total. So we had one good month in September 2021 where we had 20. Other than that, we never got above 15, I think, which is terrible, right? 850 patients. So she sent us the data for the first 3 months doing this program, and we increased almost 400%. Thank you. And we've done 132 studies total. We've picked up 15 conditionals, and we did pick up 4 abnormal studies. And those patients are now on transfusions. They never had a stroke, and that's potentially life-saving, or saving them from significant disability. And so this is really a simple solution that took a lot of effort. To my earlier point, even if it seems so simple, it takes so much effort convincing people that it's financially viable, that it's good for the patients. It seems like a no-brainer, and luckily our administration kind of bought in, because they did have to front a little bit of money. But the thing is, if from a financial perspective, that's half my job, is making financial arguments, even though I would love to just make medical arguments. We're doing more studies. When there's conditionals or abnormals, we have to do an MRI. That's a big bill for the hospital. The patients we start on transfusions, that's a big bill for the hospital. I hate talking about this stuff, but that's how the hospital views this. And so when eventually this grant runs out, our hope is it's going to be self-sustaining, right? I can show them this is paying for itself. Now you have to pay for the technologist. We have the machine, just pay for the technologist. And I think they've bought that argument. And so, like I said, the barriers have essentially been reduced to just getting patients into clinic. And on our end, those efforts have consisted of, we have a new scheduler in our clinic. Her name's Ryan Krigler. She's phenomenal, and she has a cell phone, and she texts patients to get their clinic appointments made. If they prefer call, she can call them on the cell phone. They can call her. They can text her. A lot of patients just prefer text. They don't have voicemail set up, or they don't answer their phone. I don't answer my phone half the time. But that gets the message across. And so that's been helping. Madison, our new nurse, has, I tried to convince her not to do this, but she has binders with like old school paper, and she has notes on every single patient in our clinic, and about studies, what needs to be done, what are the barriers, that kind of stuff. And so she's been amazing. I know you guys have been talking to her. And between the two of them and our social worker, Lauren Peterson, and really all of us, it's been a coordinated effort to reduce loss to follow-up patients, because we've had patients that haven't been seen in years, and we're working on getting them back, and that's an area where you guys can really help, because like I said, it's really now about getting patients into clinic, and they'll get the TCD. And so, I think we went up to March or something in that most recent data. That's going to skyrocket. Yeah, that's sort of our update, and we're really excited about it, and it's hopefully going to continue.
If anyone has any questions for Dr. Glaros, whether it be about the clinic or specifically about TCDs, and who should be getting TCDs and who doesn't need to get TCDs, because I know this is an area of great concern among our plans now, this is your chance to get a definitive answer for the questions that you have. So if you have a question, this is the method.
I'm coming.
Yes, on regards to time, how much time does that have to visit, and have you had any pushback from the families about that?
Families love it.
Can you repeat that question?
Dr. Lorenzana asked, what is the time commitment for doing this in the clinic, and has there been any pushback? And it's been the opposite. Families and patients love this. because they don't have to think about it, you know? It's just one less thing to think about, right? And again, it's not hard to convey how important this is, but as soon as you walk out the door, the world hits you, and it's a lot of other problems on your plate, right? And so, and we don't make it easy on them getting these things scheduled. So I think universally, families have loved the concept, and they're very excited about it, and it's only 10 to 15 minutes. So they walk over there from the waiting room. It's adding, I think, no time onto their visits, actually.
Alex, one thing that the case managers have said in the past that it might be helpful, how would you describe the TCD process to a patient? Like, what does that entail? How would you describe that to somebody that's never had that before, so that the case managers, community health workers can kind of help relay that information?
Yeah. So I think it's an ultrasound, right? So a lot of us have had ultrasounds. It's a little probe. Ours is a little probe. They used to use a little bit bigger one because you can have imaging or a non-imaging transcranial Doppler. Ours used to be imaging. Now it's non-imaging. It's not really that important for families, other than the fact that it's really not. So that basically they take the probe, she puts it on their head right here, right here, right here, and looks at the blood flow in the vessels. And basically the child has to sit still. It's going to be in a dark room, has to sit still, and it has to be quiet for 10 minutes. And that's a problem sometimes in some of the kids, obviously. We've had a couple with this new machine. It's a little more sensitive to sound, where we've had to send them down to radiology. It's again easier because we have a dedicated ultrasound technologist. She just walks them down herself, and she does it with the other machine because it's a little less noise sensitive. And she doesn't even ask the radiology, do you need the machine? She just sees it there, and she does it. So, which I love about her. So it's very simple. They just hold it there. They put a little gel on, get the numbers, and that's the end of it. It's really simple, you know.
Questions for Dr. Glaros?
Yeah, Clifton.
So I know this is pediatric, but has this been able to be followed until someone that's old?
Adulthood.
Or is it immediately beyond
Yeah. So TCD is a point of interest for a lot of people in a research sense. We stopped them at 16. One, because the ischemic stroke risk is higher in that early age. Once you get past 10, it drops dramatically. But then it's kind of bimodal. In adulthood, there's a high risk of stroke also. And so there are people looking at, can we pick up with TCD risk of stroke? But there's nothing definitive. So I think it's only on a research basis people are doing it in adults.
Yes.
I just had a quick question, basically a specific scenario, but member has history of stroke, is on chronic transfusion protocol, had an MRI, has never had a TCD. Can you just clarify, will they never get a TCD? Is the MRI now the standard, or what are we looking for, I guess, for that?
So the recommendation is not clear once you get on transfusions if you should get a TCD. There's nothing to say you should stop. And so in our clinic, it was always kind of understood we should be getting these, but we tend to not because we're more focused on chelation, and the MRI we definitely need. So now this again has made it easier for that. So now we are getting the TCDs on all those patients, and really it should be easier because they're in our clinic every month. And so we've been getting those too. So the short answer is yes, we should get them, because if it's dramatically worsening on transfusion, that's a big issue. Because the transfusions should be protecting you against that vasculopathy. And so the answer really has always been yes, we should be getting it. Now it's much easier, and so it's definitely we should be getting it. Yeah.
Would it be fair to say, when in doubt, get the TCD?
Yeah, and it's you know, to my point earlier where I said, you know, focus on the most important thing. like with a transfusion patient, it's like, that's not my most important thing. It's more, I need you to get your liver MRI, you know, looking for iron content. So I'm not going to focus that much on the TCD if I'm prioritizing. But now it's so easy, get the TCD.
Any other questions? Going once? Going twice?
I have a question. It's, you know, just part of practice, right? So I have only a handful of, I know the recommendation is like 9 months, they say to start the hydroxyurea. But I have some kiddos, you know, that might just be past a year, but families are saying, you know, because of their blood work, they're not being started on hydroxyurea yet. Can you explain the rationale for that?
Yeah, there's some. The recognition is in those genotypes, SS and beta 0, that's one thing. I don't think that's what you're talking about. There are some patients who have what we call hereditary persistence of fetal hemoglobin, and maybe that's what you're picking up. They just have a fetal hemoglobin that's like 40%, and that's better than what we're going to achieve with hydroxyurea, to be honest. And so we will wait to see if that drops. Some kids are just delayed in their drop, some kids never drop. And so before we start them on hydroxyurea and commit them to that, we want to see where they're going to end up, because we had this issue in some other patients where we never had a low fetal hemoglobin because we started at 9 months, but they never actually dropped below 30, and now they're on it, and we don't know, is this hydroxyurea or would you just be this anyway? Are you taking your medications and being honest with me? Are you not? You know, it's, even if they tell me they're not, then it's still high, so then it's probably, you know, so even some of those patients, we're pausing, and I want to, because I don't want you on hydroxyurea if you don't need it, you know, so I'll say pause for a couple months, let's see where this goes. If it drops, we'll start you back up. So that might be it.
Thank you. Yeah, that's what I just wanted to understand. You know, I knew there's a reason, but just I wanted to understand why.
To get a sense of how frequently that happens. What percentage, because I want to make sure we're understanding that what's common, what's really uncommon, what everyone sees. What proportion of kids are going to have a high enough level of fetal hemoglobin that you're going to say, no, don't start hydroxyurea?
1%.
1%, okay? So just to keep in mind, we think of all of these exceptions all the time, but these exceptions are really, 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 really small numbers of children. And just like we saw what happened when we spent so much time focused on the reconciliation of data that made very, very little difference, we need to not be focusing on the 1%. We need to be focusing on the 99% of kids who need the drug. And I think sometimes we get so focused on the exceptions, we forget that they're really small numbers. Focus on the big picture.
Right, I just wanted to understand.
No, I'm not mad at you.
Yeah, no. I just wanted to understand politically why that decision is made when we're following these standards of care.
It was just a great example of us, what we do.
And I've had, like I said, I've only had 2, you know, and I think it was very common. I just wanted to understand why.
Great. Thank you, Dr. Glaros.
Okay, I know there's a break in the agenda, but we're gonna skip it because I'm gonna make y'all work real hard today. And we're gonna just take it through to our next session, which is really where we started, and that was around member incentives. And let me just transition using my mad tech skills of plugging something in. My daughter thinks I'm hilarious. Okay. And I'm not holding anyone hostage. If you need to use the bathroom, like, please do that, right? We're skipping a break. So where we started this today was talking a little bit about what we did a year ago, almost a year ago, and we used the example of incentives because families said incentives are an innovative, thoughtful strategy. It's worked for adults. How do we use this in the sickle cell community? And I think if you even remember further back from that, It was a virtual meeting because we weren't actually even in person yet. And we heard from Clifton, and we heard from Dr. Sherney, and we heard from Davina, and they all said,